Well, hello, it's Mrs. White, and today's lecture is going to be about brain trauma, or in your textbook, I believe they call it head injury. So, same. So, we're going to be looking at this through the lens of next-gen NCLEX, so recognizing and analyzing cues, prioritizing our hypothesis, generating solutions, and taking action. And I have some areas down below for you to think about the diagnostics and the medications to know. Okay, so let's get started. All right, so head injury is the definition really is any trauma to the scalp, the skull, or the brain. We could have various forms of injury, acceleration injury, which is caused by the head being in motion, versus deceleration is when the head stops suddenly. Then we have that whole counter coup, where the head is in motion and then stops suddenly and smashes against the back. So most common causes of head injuries are falls and motor vehicle accidents. Lots of other different causes, sports related, recreational, unfortunately war and firearms, assaults. But that's where we're going to kind of take off. We're going to start as to like what it is and what are we looking at. So head injuries can be pretty much described as diffuse or localized. So diffuse versus localized. Something to think about here is that diffuse would be something like a concussion. Localized would be a laceration. So scalp lacerations, those are external head injuries. The scalp has a lot of vessels in it. It bleeds very readily. So that is something that we can see. We see the bleeding and it causes a lot of concern. But again, the scalp is very vascular. Skull fractures can be either linear or depressed. They can be just like any of the other fractures we learned about, comminuted, compound. They could be closed or open. And the treatment for them sort of depends on what we see. So let's just take a moment and look at the lacerations. So we can have scalp lacerations, but we can also have brain lacerations. So if the brain tissue was to tear, of course the big issue that we're going to worry about is bleeding. So we can save that for under prioritizing hypothesis. But what would we see? If we can't always see the bleeding on the outside, what might we see if there's bleeding in the brain? So we might see a decreased level of consciousness or a change in their level of consciousness or altered mental status. We might see unconsciousness. We might see pupil dilation. And it's usually a single ipsilateral, meaning on the same side as the injury. That is a terrible, terrible sign. We might see something called raccoon's eyes or battle sign. So battle sign is often called post-auricular ecchymosis, otorrhea. So let's just write these down here. Raccoon eyes, battle sign. If there is the potential to have cerebral spinal fluid leaking, if we were to catch that drainage, you might have that halo or the ring sign. So let's talk a little bit more, depending on what is torn. If it's the brain itself, we can't actually sew the brain up. That's not that kind of tissue, but we can fix bleeding vessels. So the question is it arterial or venous? Remember, arterial, by way of it being artery, would be faster and more severe. There are a couple of different types of brain bleeds that we could have, that our patients might present with. One of them is the epidural hematoma, and the other is a subdural. So just the major ones, okay? Not everything. So epidural hematoma is bleeding between the dura mater and the brain. It is, of course, a neurological emergency. They need rapid surgical intervention. And the signs and symptoms are interesting. So it's initially that they're unconscious, then they get better, and then they get worse. And some of the signs and symptoms that they have are like headache, nausea, and vomiting. Now the subdural hematoma is bleeding between the dura and the arachnoid space, and these can have varied presentations just based on the size and their location, but they're usually slower development. Of course, if it's an arterial bleed, it will be faster. But we basically divide these into three different types. We have our acute, and then we have the subacute, and then chronic. And this is basically when do we see the signs and symptoms. So for acute, it's 24 to 48 hours, and the person usually presents with a headache and a decreased level of consciousness. Subacute happens 2 to 14 days after the injury, and then chronic can be weeks to months after a basically seemingly minor injury. So these are more common with the elderly, and the reason why is because the elderly have smaller brain sizes, so they can bleed a bit more into the space before they have signs and symptoms. All right, so diagnostic studies are probably exactly what you're already thinking of. We have CT scans, and these would be the gold standard to evaluate head trauma. And then, of course, there's MRIs, there's PET scans. We might do Doppler studies. So, and then X-ray, of course. So these are the major things for us to see what's going on inside of the brain. So as we go into our nursing management, we want to prioritize our hypothesis. For this one, the biggest threats to life, of course, would be our circulation, airway, and breathing. If the person is found down, remember we go backwards. But as we're just prioritizing here, we have to understand that one of the most dangerous things for our patients, outside of the airway issue, is increased intracranial pressure, so ICP. All right, so anytime we have increased ICP, then that increases the chance of death or poor outcomes. So you need to be aware of what the signs and symptoms of increased intracranial pressure are. And we can measure them. So greater than 20 millimeters mercury is an emergency, right? Needs to be reported stat to the doctor. So that's a terrible thing. We have our oxygenation status. We may have people with head trauma often have cervical spine trauma, so we want to worry about the C-spine. But that's the big ones, okay? Our goal when we're working with patients with head injury is to basically prevent secondary injuries, figure out what's going on early, and get surgical intervention as early as possible if it's indicated. So let's go along to the nursing care of the patient. All right, so taking care of our patients with head injuries requires the nurse to be especially astute at assessment. So what things are we assessing? Well, part of our information is to know the mechanism of injury, sometimes called MOI. We want to know how did they get hurt to begin with. This can lead us to closer monitoring, figuring out exactly where we need to be, and also knowing what medications the patient is on. For us, one of the most common medications, especially among elderly, that we'll see that can lead them to a brain bleed or a head injury is anticoagulation. So are they on those? We need to make sure we're asking. So we're going to constantly be monitoring intracranial pressure and for the signs and symptoms of intracranial pressure. So even subtle behavior changes. So we're assessing the mentation, orientation, their ability to follow commands, their behavioral status. Because even subtle changes like being restless, irritable, increased confusion can absolutely show us that they're having an increase in intracranial pressure. And for the same reason, this is why we minimize sedation for these patients, okay? Because we need to be able to see why or when something is happening. So the assessment as we go on for the objective assessment, which I'm sure we'll talk about in class as well, looking for injuries, looking for battle sign, looking for edema, absolutely looking at the pupils. We want a neural assessment. Being on the lookout for seizure activity, because they are always possible, and that is a safety concern. Cushing's triad. So these are all assessments that we need to have ongoing. So the overarching goal for all of this is that we maintain adequate cerebral oxygenation and perfusion, right? So we want to avoid shock. We don't want hypoperfusion. So how do we do this? Basically, we monitor the ICP. You might have them with a ventriculostomy. The patient might require burr holes, depending on what's going on. So do they have surgery for burr holes? If so, that's an open wound to the head. So what could be a concern there? Hopefully you're saying infection. Absolutely. And here's a little tidbit, is that if somebody has a cerebrospinal fluid leak, there may not be signs of increased intracranial pressure, right? So a cerebrospinal fluid leak is almost a little protective, which is sort of like why we do burr holes, to relieve pressure. But that can lead to meningitis, which is an entire other lecture. So, priorities, again, to help cerebral oxygenation. One of the things that can happen is that the person can shiver, or they can be too, if they're shivering, it can decrease their cerebral perfusion. So our goal temp for them is 36 to 37 degrees Celsius. They might have eye issues. We can treat those supportively. If the patient actually has a cerebral spinal fluid leak, and even if they don't, even if they just have intracranial pressure, but what we like to do is elevate the head of the bed. If they are losing fluid, we would put a pad wherever the fluid loss is. We want to avoid activities that increase intracranial pressure. So sneezing, blowing noses, things that you may not even think about, basically hip flexion. Hip flexion can do that. If they have a cerebral spinal fluid leak, we don't like to give them nasogastric too. That could lead to meningitis. Some of the things we do as well is and I'm going to put this up here, the neural assessment, we want to know the Glasgow Coma Scale. So you guys should be pretty astute at doing that. I would expect that. All of us standing here today listening to this lecture, you should be a GCS of 15. All right, so other treatments for increased intracranial pressure, we might do passive hyperventilation. Let me write that down here for you. Passive hyperventilation. That is an interesting concept where respiratory alkalosis can cause cerebral vasoconstriction, which decreases blood flow, which decreases cerebral edema, right? So we try and work with their blood gases. We may monitor their ABGs anyways, but again, understanding that a patient can deteriorate rapidly, and we have to have really good assessment to catch that early. All right, so other things we do, keeping them euthermic, like I already mentioned, avoiding infection, giving them good nutrition, working towards recovery if they can to maximize their cognition, motor, and sensory function. All right, so what are some of the meds that we'll talk about here? Give me just a minute. All right, so some of our meds that treat increased pressure would be the hyperosmotic agents. So mannitol is the exemplar. So that's a hyperosmotic. Basically what that does is it basically dehydrates the brain. So it decreases cerebral edema. One of the other ones that they use is urea. So steroids to decrease cerebral edema, same thing. Dexamethasone, methylprednisolone. And we do often, not often, but we do give barbiturates potentially. I know we said to avoid them, but they do have a role to slow brain metabolism, right? So somebody who's fighting an injury, we slow their brain down, we can decrease the cerebral edema. So those are just 3 drug classes, different types that you can look at for brain trauma. Alrighty, I guess that's where we'll leave it here. We'll go into a little more depth during class, and that is that. Okay, so here is my completed form. Hopefully yours has information that you find interesting, and we'll go from there. I do want to mention one thing: prevention. If we know that people fall or they're involved in motor vehicle accidents, and that's one of the major factors for head injury, this is why it's very important that we teach patients to always wear their seatbelts and wear helmets when riding bikes and other things. Sometimes we can't prevent a fall, but we can certainly try. But motor vehicle accidents, we can save a lot of lives by wearing a seatbelt. All right, thanks.